Today, I'm super excited to have Mr. Alex Montgomery, a consultant spinal surgeon, in with us to discuss all things about back pain and spinal surgery, and just trying to bust a few myths and look at, okay, how do we manage back pain better in society? So, Monty, I often will refer to you as that because you're often known as that by colleagues. But welcome. Can you tell us a little bit about your background?
Yeah, so like you said, I'm a spine surgeon. I work at the Cleveland Clinic, London, also at Barts Health. I set up and led the team there for about 10 years. I'm still regional lead for North East London, Essex for spine surgery. I kind of split time, probably 2/3 private, third NHS now. On that side, deal with a lot of major trauma. On the private side, all the normal stuff, but I do a lot of sports, Premiership football, England, Wales, rugby, Olympic stuff, and all the other in-between sports as well. So, yeah, a lot of experience in that field. I've worked with a lot of physios like yourself, S&C guys, sports docs. So I've done a lot of Pilates, S&C myself. So I've gained quite a lot of experience for a spine surgeon.
So you're a very well-rounded individual in that.
I'm good for a spine surgeon.
Yeah. And so he's someone that speaks with a lot of knowledge and a lot of understanding about the scope of the problem with back pain, which is interesting. I wanted to perhaps just start by laying down a few stats with back pain, because I feel it's becoming more prevalent even, and perhaps we're not managing it as well as we can manage it in terms of society, that is. And so if we look at some of the stats within the UK, there's over 9.5 million people in the UK experience low back pain, and about almost 6 million experience severe low back pain. There's 2.6 million new cases of low back pain every year in the UK. And 1 in 5 workers with low back pain will take over 6 months off work, which is a massive number. And then as of March 2023, there were 995,000 people in the UK economically inactive due to problems or disabilities relating to neck or back pain. And we know that about 80% of UK adults will experience a significant episode of back pain in their life, about 70% for neck pain. Now, just how big an issue is back pain in the UK today, Monty?
Yeah, I mean, it's huge, isn't it? I always say when people come to see me in the clinic and they say, oh, why am I getting back pain? I've done all the exercises, whatever. I say, well, apart from the common cold, back pain is the most common thing that anyone gets from my point of view. Like you said, it's hugely prevalent. It's what I do, and obviously to me, it's really important. But in some ways, it's nice to hear that figure because for me, we haven't done enough to educate people, and that's the key to it. Really, is education.
So educating the wider community, educating patients in terms of causes, but also how they can reduce the recurrence, because the recurrence is very high as well, isn't it?
Yeah. I guess the problem is it's so nuanced, isn't it? When you go to the gym, your physio has told you to go to the gym and do these things. You go to the gym and you haven't got that knowledge or experience, and maybe you don't want to know whether you should be lifting 30 or 40 or 60. You're not quite sure when to stop. You actually don't know when your technique's going off a bit. You know, you're not sure whether you're doing too much of the same thing all week, whether you're varying it enough, whether actually you need a week off. We all know. We go to the gym or we do an exercise, we wake up and we know, oh, do you know what, today I'm going at 70% today.
Yeah.
I'm not doing more than that. You know, I'm not going to push that leg press past 150 today because I know my body's not ready for it.
But that's the ability that you've got to listen to your body, which...
And there's all the education experience we have from this. And so for people, I think like we said earlier when we were talking beforehand, what strikes me when I talk to parents on the touchline at the weekends is just their lack of accessibility to who to go to.
Yeah.
Whether it's for physio, they have no idea. The building looks nice, the website looks nice. Whether it's chiropractor, should they go to an osteopath? Should they see an S&C guy? When do you see a spine surgeon? They have no idea, most of them. And it's just having that right person to go to, then getting the right education, and then being able to translate that into your body.
Yes, because there are, if we step back, there are lots of people in that pathway.
Yeah,
and maybe we'll touch on that in a little bit later. But you know, there's osteopaths, chiros, physios. there's massage therapists, there's S&C, there's Pilates instructors, there's PTs, there's your GP, there's sports doctors, there's rheumatologists, there's spinal specialists, there's neurosurgeons who
Do a bit of back.
do some spinal work. So there's a whole host of people within that who are treating and trying to manage back pain, and sometimes not always giving the optimal advice.
No, exactly.
But from an economic point of view, and from a general, in general sort of healthcare terms, how big an issue is this? Because it actually costs society an enormous amount. I mean, a figure that I was looking at was that over 12.3 billion annually was spent on back pain, which is extraordinary.
Yeah. I mean, it's incredible. 10 billion. So you'd wonder why we don't spend $1 billion kind of educating people and trying to get it right. So I think the figure is this year, what was it, 200 billion budget for the NHS. We're 7 billion over. And actually, you could reduce that significantly by just tackling back pain alone.
Yeah.
So I think it's a huge issue. I think it's, apart from a cold, viral, COVID, things like that is the biggest issue we get. Obviously, it doesn't hit the headlines like heart attacks and strokes.
No, because people
cancer.
are generally not dying of
They're not dying straight away. It's not an
back
A&E
pain.
thing. And we're very good in this country, in the NHS, at emergency care.
Yep.
Whether it's trauma, heart attacks, strokes, all those kind of things, emergency surgery. It's the slow burning things that we just requires a lot more education. It requires a lot more effort.
Yep.
It requires going to the right people.
Is that why you think treatment of back pain is slightly misunderstood?
Yeah, I think
because there's a lack of awareness or education amongst the general population about how to manage, what to do.
Not just general population, doctors. So I was speaking to a doctor colleague of mine who's an ENT specialist the other day, and I saw him kind of shuffling around and putting his hand on his back and everything. And I said, "What's up?" And he goes, "Oh, it's just, it comes on every couple of months." And I said, "Have you seen a physio?" And he went, "Oh, come on, they're not going to do anything, are they?" I mean, exactly.
Yeah.
He's an ENT specialist, but you're not taught at medical school how to manage back pain, by the way.
Yeah.
You're taught the anatomy of the back.
Yes. Yeah.
You're not taught a physiotherapy is a tick in a box.
Yeah.
That you give people if they have back pain and there's no surgical solution. There's no understanding. I learned all my knowledge about physio, rehab, strength and conditioning through people like you, like just talking to loads of people over the years, doing it myself, educating myself, and then applying that to patients, seeing what works, what doesn't work, and then 17,000 patients later, you have a very good idea of actually, what will work with that particular patient.
Yeah.
And to go back to your question about the impact, I think it's massive. We haven't given it enough input. I spent a long time as lead at Barts and also as North East London Essex chair, trying to get people to approach this in a multidisciplinary way, where you don't get GPs referring every back pain to a spine surgeon.
Yeah.
Which up until the last...
Because they just don't need to see them.
No, you get 3 lines on a referral saying, please see this patient with back pain. MRI scan shows multiple level degeneration.
Yeah.
They've not seen a physio. They've not had any advice. And they're coming to see us. And then we'll either say, go and get physio or have an injection. And that'll happen a year later.
Yeah.
So we haven't really tackled that huge issue. And then you get into this kind of chronic pain cycle, as you know.
Yeah, which can be incredibly difficult, because I think you touched on it, and I want to get to a point where we're trying to just throw out some myths about back pain in a second. But back pain is very nuanced. When I started treating it, it was like, oh, okay, well, flexion irritates someone or extension irritates someone, so it must be this or this. But it's, as you've been in the field significantly more and you understand the sort of factorial components of back pain, you realize that actually it's significantly more nuanced than that.
Yeah.
And it's not just the structural approach, or, it's about movement patterns and movement disorders and strength, but also what's happening at that structural level.
Yeah, exactly. So I always tell patients I'd think about 3 or possibly 4 aspects to why people get back pain. So firstly, most common, biomechanical. Biomechanical itself is split into so many things.
Yep. What's
your posture? What's your movement patterns? Like you said, are you tight? Are you weak? Are you strong in the right places? Are you weak in the right? All those things that a physio looks to assess.
Yep.
And then, also what are you doing in your job? How long are you sitting? All those kind of things, biomechanical. And then there's the anatomy.
Yep.
And you can judge anatomy by looking at a patient, examine them, or doing an MRI scan or both. That's the second aspect.
Mm-hmm.
And then there's inflammation. Like some people get mildly inflamed, some people get very inflamed. Some people have inflammatory disorders that mean that, you're going to get pain at certain times, even though your anatomy doesn't look too abnormal.
Yeah.
And there's quite a spectrum of that. I've learned one thing about inflammation. It's not you have inflammatory disorder, you don't have. It's a spectrum.
Yeah.
And at some point, that spectrum along the way, sort of 3/4 or 80% of the way, rheumatologists decide that you have this particular condition because you fit the criteria. Just because you're 3% that way and you don't have it doesn't mean you don't follow an inflammatory pattern.
Yes.
Which
is often the trouble in medicine, I think.
Yeah. So rheumatologists are fantastic. They're extremely useful. They're just it's a little bit difficult when a patient follows a completely inflammatory pattern but is negative to their criteria.
They're testing. Yeah.
And then they don't fit any of the biologics or any of the other medication, which are often transformative in dealing with these things.
Yep.
So when patients come to me and say, I don't understand why I have back pain, for that particular scan, why do I have back pain when 8 or 9 out of 10 people don't? Well, because I have no idea what you do every day, what your muscle strength is, how you're moving, what you're lifting, what your job is, what physio you've done, what exercise, what stretches, whether you do Pilates. I have no idea about that, or your inflammatory system from the MRI scan. So and then, of course, there's the psychological aspect, which is the fourth bit.
Yeah. So, that's why it's so nuanced, because there's so many factors that can contribute to having back pain. So I'm going to just throw out a few questions for you, and we're going to sort of try and bust a few myths here if possible. So back pain always comes from a slip disc.
Yeah, obviously that's not true. Always is never the case in anything medical.
Yeah.
But no, a disc is one of the many reasons one might get back pain. You can get pain from the joints, you can get pain from ligaments, you can get pain from muscle. You can get pain in your back because you're a bit inflamed, or you haven't slept well, or you're stressed, or there's so many reasons why one can get back pain. So there's a lot of times I get referred patients where degenerate disc has back pain, and that's what the patient has in their mind, that they have this pain because of that. And actually MRI scans for me are just a fabulous thing because it gives me an anatomical image in a patient who I've already biomechanically and partly psychologically assessed. Not the other way around. But as you know, Peter O'Sullivan in Perth, Kiwi, but in Australia, he's written a lot about language one uses to patients.
Definitely.
With the MRI scan, it's hugely important.
Yeah.
So in my practice, I've turned the MRI around from being the baddie, that we should never do, and never tell patients about, to being the goodie, because basically it's saying, oh, look, all these changes are completely normal for your age group.
Yeah.
Because in time, your joints, your discs, your back will change with time. That's normal. Just like skin wrinkling, just like losing hair, just like all the things that happen when you get older. It's normal.
So are you quite careful in the language that you will use when you're describing? Because we have situations where, a patient will come into us with a scan that their GP has sent off and it's been reported as multi-level degenerative discs, and they'll be very, very hung up on that. But actually we know that 50% of the population out there are probably walking around with degenerative discs that aren't necessarily painful.
Yeah, more. Exactly that. I'll just look at the scan and say this is relatively normal for your age group. By and large, the entire scan, there's one little bit in the right corner here, which is still within the bell-shaped curve of normality, but you're probably a bit above average. So I kind of try and label it like that. So it's good to know there's a reason for your pain as well.
Yeah.
If you go to someone and say, oh, your scan's normal, there's nothing wrong with you, just deal with it, go and do some physio. Patients don't like that.
No.
I think if you have, and most people that come to me, because we've got great physios around and great people where they kind of filter them before they come to me. Most people are around, there normally is a reason in the scan for me as a spine surgeon.
Yep.
So the patients like that when you find something.
So touching on that, do MRIs always tell you or give you further information about why someone's got back pain?
Yeah, always. Most of the time for me, I think, because I'm seeing it filtered out.
Yes, okay.
Bunch of people. So like for every 10 people go to, you probably send one.
Yep.
So I see that one, and you're an experienced physio, so most of the time it'll be helpful, let's say.
Yeah.
It doesn't tell me. Most of the time, when they talk to me and I examine them, I can pretty much tell, you can pretty much tell what it is.
Yeah.
The scan is just there to try and fit in with that and see which bit of that scan is relevant to their symptoms. Occasionally, 5% of the time or whatever, there'll be something there.
Yeah.
That's obvious, like a spondylolisthesis, like a slip, the bone slip, or something else like that. If you've got a large disc prolapse pressing on a nerve, then normally you can tell beforehand, right?
Exactly. So the MRI is almost just confirmation of your clinical diagnosis.
Yeah, and also I think it's good to know, you've done, let's say, it's been 3 months, you've done quite a bit of physio. Are you one of those people where, this is just going to take longer?
Yeah.
You don't fit into the category of 80 to 90% of people where they're going to get better in 3 months.
Yep.
Yours is just going to take a bit longer, or actually this is quite a large disc prolapse, just be a bit more careful, or you might be more likely to need a steroid injection to help calm it down from that. Or very occasionally it's like, well, actually we need to do something about this, but that's normally the clinical aspect rather than the MRI scan.
Yes.
Because if you're having to jump in and do surgery on someone, it's normally because of some kind of neurological deficit, which you can assess clinically, not by the scan.
Yep.
I had a Premiership rugby player I just saw yesterday, huge disc prolapse, and reported by the local radiologist, cauda equina, so they came straight away.
Yeah.
And actually over the course of last week, his leg pain, sciatica is gone.
Yeah.
His numbness is improved. He has no worrying signs. Cauda equina, as you know, is when the nerves, the bowel and bladder get compressed.
Yeah, a medical emergency.
Yeah, medical emergency. And it's a huge disc prolapse. It's taking up like 85% of his spinal canal. We're watching it.
Yeah.
Because we're going on clinical grounds. He's moving, pain's reduced, numbness is gone.
And that probably perhaps diving in a little bit deeper than everyone wants to hear about, but that's interesting because it feels like we've got people like yourself have got smarter and better at managing those type of situations because we've seen that actually that disc can almost resorb and resolve in the first sort of 6-ish weeks if you're careful and you advise appropriately.
Yeah, exactly. So I think we're quite good in this country. We're quite conservative. We're good at waiting. My experience of getting people from other mainland Europe or even from the US, Canada, wherever is, we tend to wait a bit longer because we know that most people get better on their own.
Yeah.
So either, with a disc prolapse, we know that most of these will reabsorb over time.
Yep. Okay.
And most people get better with physio as well. So we're pretty good at this country at that,
cool.
I think.
So another little myth, a lot of patients come in and say, look, I've got a disc bulge. Do I need surgery?
Yeah.
How often, or, most of the time, I would say with the patients that, we're managing them conservatively. Maybe they occasionally need some help with some steroid injections, but it's only the ones that have marked sort of neuro sort of features, a foot drop or loss of power that really need that surgical consideration.
Yeah, exactly. So I think we said like 7 to 8% of people I see end up being recommended surgery. It's not normally on the first visit either. So if you've got leg pain with no weakness or foot drop or any worrying signs, then let's say you're 3 months down the line, we'll decide if you're able. So the point of a steroid injection is to do the rehab. Yeah. So in fact, I say everything in my practice is for rehab. The reason I even do surgery for sciatica is to get you back to rehab. I'm just trying to make the rehab easier.
So it's almost a window to provide that opportunity to really make some change to how someone's functioning.
Exactly. Yeah. And most people will get better on their own. So that if you do need that steroid injection at 3 months or 4 months or 5 months, it's purely to try and reduce the inflammation, swelling around the nerve, so you can do your rehab and continue with it.
And it massively helps us as a physio, you reinforcing that and telling patients that, because they then go, okay, right, well, I'm going to just really focus. I'm going to dedicate this time and use that period, because the steroid injection doesn't work always forever.
No.
But it definitely gives you a lot of the time a very good window.
Yeah, exactly. And I think it's quite important also to give patients a rough timeline. They want to know that they're not just being fobbed off as well.
Yeah.
Like, because some of them are in severe pain. Some of them are in so much pain they just want to get it done. And just try and reassure them, say, look, 85 to 90% of people in your scenario will end up not needing surgery.
Yeah.
So what we need to do is try and reduce your pain one way or another, whether it's tablets or with, physio or neural glides. Sometimes you do neural glides and the pain just reduces, right?
Yeah.
Or a steroid injection, but we'll get to a certain point, we'll try one, get back to physio. If it still hurts, we'll try a second one.
Yep.
And it's often on their third, fourth or fifth visit that people come back to me. We go, okay, well, now you have a choice. Either we live with it with pain management, or we do surgery. This is what the surgery involves.
Yep.
And then just giving that advice. And I think it's also important as a surgeon to give the risk of not operating as well.
Yes. Yep. Yeah.
I think sometimes we forget about that because
Yeah.
people obviously know that every surgery has risk, which of
yeah.
course it does. But actually, sometimes not doing something has
Correct.
risk as well.
Yeah. You touched on a point there that I just wanted to loop back to, that surgery generally, okay, when we're talking lumbar spine pain, is more often done for loss of power, and rather than just leg pain, because a lot of people will start getting a lot more concerned when they have back pain, but then leg symptoms. Now, a lot of people can get leg symptoms, but actually generally we're less worried about that. We tend to be more worried about a loss of power, a loss of sensation, and then certainly that sort of foot drop generally. Is that how you see it?
Yeah, no, exactly. I mean, surgery for pure leg pain without weakness is for persistent pain that significantly affects your life and has not got better with rehab or anti-inflammatories or injections.
Yep.
So it's something along the line, So when people come back to you and say, "Look, I'm done now. I did everything you told me to."
Yeah.
Okay, fine. In terms of for a foot drop, I mean, the question of how long do you wait with a foot drop? There's a nice paper that's come out recently with my name on it and a few of my colleagues on foot drop. But I'd say, in short, it's okay to wait 4 to 6 weeks.
Yep. Yeah. So that initial period is 4 to 6 weeks to see if that improves. And if there's no improvement, are you then needing to act on that? Do you think about a steroid injection in that period, or you just wait?
Yeah, no, generally wait unless it's really severe pain, they can't tolerate it.
Yep.
And I'll keep an eye on it. So if they see me at 2 weeks and it depends on the level of the loss of power.
Yep.
So if it's significant loss, like you can barely move it, then you probably should just go and operate.
Yep. Okay.
If you've got, like we call 3 out of 5.
Yeah.
3
okay.
plus, so let's say 50, 60% of your power, then I think it's reasonable to wait 4 weeks, 5 weeks. But what I do is if I see them at 2 weeks, I'll see them again at 4 weeks. And then at 5 weeks, we kind of make a decision and generally intervene just after that.
Yep. Okay.
So I give people, and I even say to people, like, even if it starts improving in the 5 days before the surgery, let me know.
Yep.
Because we know, why don't we want to make much longer than that? Because we know that outcomes drop off. They kind of drop off a cliff after about 6-8 weeks. So your outcomes significantly reduce.
Yep. Okay. And you touched a little bit on, you mentioned sort of neural glides as something that can be effective in helping modulate pain a little bit. Talk me through about what you understand about sort of neural glides.
Yeah, obviously I'm not a physio, but I've been through many physio sessions where people showing me what they do and stuff. And you can do glides on a reformer, you can do neural glides just with a physio in your own, getting on an exercise bike is a bit like a neural glide. So when we move in our day-to-day life, when we're walking, when we're running, when we're bending, the nerve glides, it moves over a smooth, shiny surface, which is the disc.
Yep.
And that's what we rely on every day.
Yep.
If the nerve is inflamed and you're doing it, you're going to feel something there.
And how much does the sciatic nerve actually glide? Say when you're doing some lumbar flexion, it's relatively substantial, isn't it?
Yeah, I think it's
sort of
pretty
five
substantial. Yeah,
5+ centimeters or so.
I don't know the exact amount, but yeah, it'd be a decent amount. Probably not as much as 5, but it'd be a decent amount.
Yep.
And so if the nerve is inflamed, it's going to hurt while you're doing that. Now, if there's a disc pressing on it, it might be almost stuck to the disc, tethered to the disc. So when you lift your leg up, boom, it's not gliding, so you get the pain.
That's a positive straight leg raise or something like that.
Yeah, exactly. And if you've had previous surgery or there's scar tissue there, then people feel that kind of pulling pain that they get, and you know that it's probably stuck.
Yep.
And, there's different words, neural glide, neural flossing. I think those words are all appropriate, neural mobilization, because it's almost like you're polishing the nerve.
Yes.
You're kind of, it's all stuck, and, and I'm a great believer in the neural glides. You can do one set of glides on a reformer, and then suddenly your pain's gone.
Yep.
Or it's significantly improved.
There's a small caveat to that sometimes it can also irritate people as well.
Yeah, because you're stretching the hamstring while you're doing
and so, you've got to you've got to just be a little bit cautious about how irritable that
Yeah.
sort of neural system is
Yeah.
when you do that. But yeah, it can be sort of super effective.
But it's like a lot of things, it's nuance as well. So I had a mild sciatica years ago, and I went to a really good Pilates instructor who's a physio.
Yep.
And she took me through some neural glides on the reformer. That next week I had more pain than it wasn't a lot of pain. It was like 4 or 5 out of 10, but it was still more pain than I've ever had.
Mm-hmm.
And I came back and it was settling down. And I told her, by the way, that one didn't really work for me. She took me back to the reformer to do the same thing again. And I was like, are you out of your mind? Thinking in my head. And she said, we're just going to modify it slightly and do it again. Boom, pain was gone.
Yeah. Yeah. And so, all of this is very nuanced, based around sort of the spinal anatomy and the biomechanics and how you're gliding, through that whole sort of tissue.
Yeah, yeah. And that takes experience in the physio, to know that actually in this particular situation, you can do that.
Yeah.
But it just shows how just slight change in technique and in what you do can change, the outcome.
Definitely. I think that brings us really nicely to sort of next little segment where we often throw around words, motion is lotion, movement is sort of magic, and, movement is medicine and those sorts of things. Is it safe for people to exercise with back pain? Because there's this real misnomer that we should rest when we have back pain.
Yeah, I mean, rest was the old wives' tale, wasn't it?
Yeah.
And culturally, in some parts of the world, that's still what people do.
Mm-hmm.
No, I think the motion is lotion is true for the back.
Yep.
You need to move.
Is there a period where you can, rest a little bit, a day, 2 days, if it's very, very acute? Or is it the case that actually getting up and going as much as you can is the best approach forwards?
Yeah, so set aside fractures and things, obviously.
Yes.
For normal back-related pain, whether it's sciatica or whether it's just back pain or axial back pain or whatever, I think if you can move, you should move.
Yep.
The only reason you should be on the floor or on the bed is if you've got, some people with especially disc-related back pain get severe spasm.
Yeah.
No matter what your age, you could be 20, you could be, 60. Some people end up on the floor with back pain. And, if that's the case, that's fine. But really it's about moving, getting yourself moving, getting the muscles activated.
Yep.
Trying to teach your body that actually you want to continue moving.
Yep.
Because it's a kind of prehistoric thing for our body, because it detects a problem there, so it stops you moving.
Spasms everything up. It's a survival mechanism, isn't it?
Name me the last time walking caused an exacerbation of back pain.
Yeah.
Yeah, sure, if you do like 20,000 steps a day when you shouldn't be, then. But yeah, what exercise is key. The nuance is really what kind of exercise.
Yeah. So
and to what level you should be doing.
So what do you advocate? Are you now you talk about Pilates and you talk about strength work. Is there a specific type of exercise at a specific time that can be useful? And we talk about back pain being nuanced. So I'm sure your answer will probably reference that. But do you have a preference, and what sort of outcomes do you see?
Yeah. So it depends on what they're telling you. What you examine, what the scan shows, and then a discussion with the rest of the team like yourselves. So let's say they have a big disc prolapse pressing on the nerve and they've got kind of moderate pain. It's not severe, it's moderate, they can move around. So I would say, obviously walk when you can, take anti-inflammatories. Happy for you to get in an exercise bike.
Yep.
Generally, most of the time a cross-trainer, although you should assess whether they're getting that tethering of the nerve that you talked about, because that can be irritated on the cross-trainer. Generally, front crawl, backstroke swimming is okay.
Mm-hmm.
I wouldn't load, like I wouldn't lift, heavy weights.
In the acute phase.
Yeah, exactly. And then as things are settling down, then you can start, thinking about introducing some form of, lightweight, then moderate weight, and then, just basically you're testing to see where you are and trying to build your mobility and strength. And, at the end of the day, that's how you're going to get rid of your back pain. I always talk about thresholds. So, if it's back pain, I think there's two parts to it. There's the load you're putting through your body on a daily basis, whether that's, your posture in your work, your exercise, whatever you're doing every day. And then there's your back's ability to deal with it. Now, if the load you're putting through your body is more than the ability of your back to deal with it, then you are going to get inflamed.
Yep.
You're going to put pressure on your discs, and then you're going to have back pain. if you can switch that, so activity modification, increase mobility, strength, stability in the back, then you can keep on top of that.
You're almost building your tolerance level up and up.
Yeah, exactly.
Which is what we see, these athletes and the athletes that you work with and I work with, they're incredibly strong now in the gym.
Yeah.
And they're doing a lot of this to prevent injuries.
Yeah.
They're doing a lot of this to build that support network around the spine, because inherently the spine's a strong, bloody structure.
Yeah.
Exactly. It's got a strong cage around it, but actually it needs the whole system moving and working efficiently to support it.
Yeah. So I often say basically what you're doing, and patients tend to like this comment, is you're raising the threshold at which your back gets inflamed.
Yep.
Yeah. So you just keep raising it. So obviously we can't eliminate, the chance of getting back pain.
Yep.
But at least raise the threshold at which you might get injured or you might get inflamed, and which you get that response.
Yep.
And that's essentially what you're trying to do by...
And that's a nice way to look at it, because I think there's so much evidence out there that supports the use of exercise and getting people strong with proper lifting for persistent or chronic sort of low back pain.
Yeah.
Maybe not in the initial acute phases, but as things have settled and that persistent pain is still around, getting people moving and moving normally is a really key factor, because a lot of the time this acute phase sort of creates this sort of kinesiophobia or real fear of movement and pain. And that's hard to deal with. Do you have an approach to...
Yeah, so I have the same conversation I had with you now about movement, about muscle activation. So I always say to them, there's several steps and it has to be in this order. Mobilization first.
Yep.
Well, reduce inflammation, one. Mobilization, muscle activation, strengthening, conditioning, then goal orientation to what you want to try and do.
Yep.
So you've got to do it in that order. If you start loading before you have mobility in the joints, as you know, you're activating the same muscles.
Yes.
I get strength and conditioning coaches who are generally inexperienced coming to me saying, their technique is perfect. They lift 150 deadlift, but they've got back pain. And I scan their back. And one of the advantages actually, which is really underused of an MRI, is actually looking at muscle mass.
Yeah.
That's a whole different conversation.
Yep.
But
are you referring to sort of multifidus in particular, or the whole muscle mass, psoas, all the paraspinals, even the hip and the gluteals?
Yeah, so glutes you can see, obviously. The glutes, it doesn't take too long to see wasting in the gluteal region. Someone's had pain for 6 weeks, you'll normally see it in the scan.
Yeah.
If they've had pain for a year, you'll definitely see it. Multifidus, yes, and the psoas. Like when I get someone who's really, I had a MMA fighter I saw a few weeks back, who I just from talking to him, examining him, looking at his scan, I thought this guy knows exactly what he's doing.
Yeah.
I mean, he wasn't big and muscular, he was slim, but his scan, the psoas was just ginormous.
Oh, really? Yeah.
It was huge.
Okay.
And his multifidus massive. I thought this guy knows what he's doing.
Yeah.
Yeah.
So he's training well, because for me, I think you need stability and an endurance capacity at postural levels, and then load. And then you build that strength within the whole sort of system.
And then there's that question I always get asked at the touchline again: should I be deadlifting?
Yeah.
Yeah, that's a perfect example of where should you be deadlifting? Is deadlifting good?
Can we throw squats in there as well? A back squat. So
sure.
Deadlift and back squats.
Yeah, two different things, I think. People tend to ask more about deadlifting. Is it good for you? I mean, deadlifting, as you know, is one of the most amazing ways to build up what we call posterior kinetic chain. So muscle mass in your hamstring, your glutes, your core, all those muscles. One of the most efficient ways of doing it. So it's amazing. There's caveats to all of that. You've got to ensure you've got the right mobility. My nephew, who's about 16, all 16-year-olds want to lift now.
My 14-year-old's in the gym doing deadlifts.
Yeah, so he's doing deadlifting. His dad said to me, can you see how he's doing it? Because, I'm a bit worried he doesn't know what he's doing. And he had zero ankle mobility. Yeah. His Achilles tendon was really tight. As you know, how do you deadlift when you've got zero ankle mobility? And I was like, okay, stop. It took me like 5 seconds. It's like, okay, you need to...
Yeah, because you're going to load something else up the chain.
Yeah, exactly. So first of all, technique right, mobility of the joints has to be right. And then you've got to know the load that's appropriate for you. Yeah, sure. Some people are training for Ironman. Some people want to do triathlon this year. They have a goal. Some people are elite athletes, different category. That's their job. You know, you got to know what your threshold is, what your load, your maximum is, and just stay under that.
Yep.
You know, and I think it's dangerous to have a goal. Right, this year I'm going to get to 180. That's where you run into problems.
Yeah.
So deadlifting is an amazing thing, like swinging a kettlebell. Probably the most efficient way of building.
Completely. They can be very, very good exercise for people.
I can't remember the last person I saw in the gym when I've gone that's done it correctly.
Yeah.
I think it's hugely dangerous when these people have no idea what they're doing.
Yeah.
Back
so
squat,
technique is critical.
Yeah.
And caveating that, we often, we're definitely a lot more cautious if someone's had a fairly large sort of disky issue sort of progressing to deadlift. And some of the time, if we need that motion, we'll go single leg work where we can change the lever length. And then you're changing that force through that lumbar spine, which for me, I think helps to reduce that overall load through your lumbar spine.
So I think I think it's key to be flexible about what exercise you're doing.
Yeah.
Like, so if you've been told the deadlift is not good for you because of these and these, and there's some situations where I do tell people you just can't do it.
Yeah.
And even when they get better, probably best not to. But then you've got other options. You've got the trap bar.
Yeah. And trap bar deadlift is an amazing.
Yeah, because basically the problem with deadlift is if your technique's not right, you're bending over and you're doing all the things that put the maximum amount of stress through your discs and your joints.
Yeah.
And so the trap bar takes that out because you're standing in the middle.
Ergonomically and biomechanically, it improves the movement pattern.
Yeah, exactly. For me, I think deadlift's a fantastic exercise to a lot of people. For me, it suits me to a certain degree, but actually I prefer doing the trap bar. I prefer doing leg press.
Yep.
And actually with leg press, I can really push my...
So long as you're optimizing your spine.
Yeah, exactly.
In your leg press position.
Back squat, I think, again, it's close to your body. You need to do all the prep before then.
Yep.
You need all mobility.
Because it does increase the spinal load.
Yeah.
And, we know from even bone health point of view, back squats and deadlifts are 2 of the 4 exercises that actually help to optimize bone health through the spine.
Yeah, exactly.
So there's load there, but actually mild stress in a controlled, good way actually helps to build that support system.
Yeah, as you know, you very kindly gave me a couple of books for Christmas.
Yeah.
On longevity and other things. So the one thing that is validated to show to increase your longevity and in effect reverse the process of aging is building muscle mass.
Yeah.
And hence with muscle mass comes bone mass.
Yeah.
So it's actually essential, but it's again doing it in the right way.
Yeah.
I mean, they say like you can tell like the health of a 75-year-old by the way he shakes your hand, right?
Yeah. Grip strength.
Yeah, grip strength.
Yeah.
Yeah.
And being in the weights, having to hold dumbbells, having to hold bars actually improves that. So it's one mode. Is it as a general overview of strength, someone's grip strength is a particularly easy marker to test.
No, exactly.
So when would you advocate Pilates within that? So we've talked a little bit about S&C and the relevance for that, perhaps later stage. How do you see Pilates or that style of control exercise sort of fitting into things?
Yeah, sorry, we jumped to S&C. So I'd see Pilates before then. I think it's although a lot of people do it, it's very underrated. I think everyone should do Pilates.
Mm-hmm.
I think certainly everyone that's
I think that anyway as well. I'm an advocate, but
everyone that's pregnant, post-pregnancy should be doing it. I think everybody should be doing it. So, I think it's an incredible way, especially with the reformer. You have all the slings and springs that assist you in your movements and pull you and get you carryover in range that you can't do otherwise. And yet it's actually providing resistance. So activating muscles, you will no way kind of activate if you weren't using it. And you come out of a Pilates session, you think, well, I haven't really done very much. That was all a bit easy. And you wake up the next morning, everything's hurting.
Yeah.
And you start feeling bits on your glutes and, in your upper
things
back.
that you don't usually work.
That you don't usually work. So when do I use it? Let's say someone's recovering from sciatica.
Yep.
And they've had some sessions of physio and basically it's coming down, it's less acute and it's either mild or gone. I think that's an excellent time to do Pilates. You can do mat or I love the reformer.
Yeah.
And the thing to realize, as you know about S&C, strength and conditioning, and Pilates is that the amount of training that person has is extremely variable.
Yeah.
So there's no set degree for that.
Yeah.
So you could be a very experienced physio.
Which is a problem in exercise science and our industry, because there's no governing
there's
bodies.
no governance for this, which is incredible, really, because you have to study 4 years or whatever to be a physio, then you've got to go to hospitals, and you've got to do this training, then you've got your seniors keeping an eye on you, and you're doing physio, which is great, with some strength work. These guys are doing more dangerous things with weights, and that you could literally get trained in 6 weeks or something. And so the same with Pilates instructors. Some are experienced physios that have done years of Pilates. Some have just done a 6-week training course, and some are physios, some are Pilates instructors. There are some Pilates instructors who aren't physios who are amazing. So
we have a few, but
yeah, exactly. So it's about getting the right people, knowing where to go. And I'd say my biggest strength, to be honest, of everything, is knowing where to send people.
Yeah,
that's
key, because and there's a lot of Pilates classes out there, and patients will often ask, well, can I just not go to a Pilates class? I'm like, look, you're going to be maybe one of 6 if you're lucky, or one of 10 or 12, and you're not going to understand the basics. And actually you need to learn, particularly if you're coming back from a bout of pain, you need to learn the nuances involved with, okay, what's the appropriate spinal position? Where do you switch on some of your deeper system? How do you move? And the positioning through those movements. So,
I mean, I would say that Pilates classes are not for people with a back problem. Yeah, you go to a Pilates class for well-being, for improve your range, to improve your muscle adaptation, for fitness, for all well-being, all the huge benefits of doing Pilates. When you've got a back problem, do it one-to-one until you're better. Then you can go to a class.
I mean, we use, with a lot of our athletes, we use Pilates as an injury proofer, because it really helps. If someone's training hard, they've got some significant volume, whether that be running, whether it be S&C work, they develop muscle imbalances, and they sometimes lose a little bit of stability or mobility. And so Pilates helps to maintain that within the system. And we really find it just helps to stabilize the whole system so that they're more efficient. It won't purely get you stronger, but you'll get stronger through Pilates with your S&C.
Yeah, exactly. It's almost like you're prepping yourself for S&C. That's the way I see it. It's a step up from physio in the sense that you can get more carryover, you can get more muscle activation than without it, and it's prepping you for doing the S&C stuff, which is basically going to load. It's back to what I said about if your mobility is not good, muscle activation is not good, then you're just going to be loading the same muscles or loading the wrong things when you start lifting.
I love this discussion. We've chatted a little bit about young athletes and the sort of injuries that we're seeing with young athletes. And I know, we've got a big database of families and parents, and a lot of parents are worried about, their kids with back pain and lifting and that sort of thing. But we're seeing a cohort of very good young athletes who are having lots of little injuries and some more significant sort of stress injuries through the spine. Why do you think that is?
There's a long answer. I'll put it in short. I think in short, I think it's probably underdiagnosed. Sort of back injuries in kids. Kids being anywhere from 8 years upwards up to 18. When I say back injury, I don't mean fractures. I mean like injury to the disc. The disc is torn, a bit of a bulge. Because kids get, as you know, where anyone's had a kid, there's something that terrible happens on the football or rugby pitch, and then within 5 minutes they're fine. And they get over it really quickly. The next day, a bit of ice, anti-inflammatory, a bit of Junifen, they're gone. They're back at it again. But actually, probably something happened. There's that, and then there's what you're probably alluding to, the past stress injuries. So I think they're definitely underdiagnosed. I see a lot of kids from the football academy. So as you know, the academies are just huge now.
I mean, they're big beasts. And
and they, I don't know what the figure is, 1 in 500 or 1 in 1,000, 1 in 500 from the football academy actually make it. So there's loads of them. It's pretty brutal. And it's brutal. And, when you're Ronaldo, you sleep exactly correct. You know every calorie that's going through your body. You're managing your stress. You're doing everything. You know everything. You have access to everything. I mean, I can't name names, but, I've got kids who are going to be significant football players, whether they're from the UK or Brazilian or whatever, who are out night clubbing, You know,
Yeah.
they're on there. You know, the coach is telling
not
me,
doing everything that they need to be doing.
yeah. The coach is saying, by the way, he's always up at Novikov or something like that. You know, it's like, well, they're on their phones till late.
Yeah.
You know, they're not prioritizing sleeping. They come home, they eat chips and baked beans and stuff. And I was under the impression before all this experience that kids who are on the track to become, you know, Chelsea players, Man City players, or whatever, were having all of these monitored. They're not. So, so that's the first thing. I think all the factors that we look into that put extra stress on your back, like sleep, food, diet, stress, all those kind of things aren't being managed. And then, you know, you're like when you get the past stress injuries, it's in those sports that have hyperextension and rotation.
Yep.
So American football,
Cricket.
Yep. Football. How often do you see it in a rugby player? Not a lot. It's a flexion-based sport. People are going in flexion.
Because they're down.
You know, it's not an extension-based sport so much. I can't remember the last one. In fact, the only past injury I've seen in a Premiership rugby player was someone who used to be an England cricketer.
Okay.
Yeah. So that's actually the only time. Whether it's from that or not, I don't know. But interesting.
More disc issues with your rugby players.
And
neck stuff.
80% of my rugby players are front row forwards, and then 20% of the rest like back row and everything like that. But so it's when they repetitive hyperextension and rotation, and I think the sheer amount of training they're doing, they're not recovering.
Yeah, so it's a load issue, really.
Load. And if you look at footballers, it actually made me think, seeing all these, there's an epidemic of past stress injuries in young athletes. I mean, it's incredible. In September, from the Premiership, in the first 10 days of September, I got referred 9 separate kids between the age of 17 and 24 from the Premiership.
I mean, that's just me. That's remarkable.
That's just me.
Yeah.
I mean, they must be sending them to other people as well.
Yeah.
I mean, I do get quite a lot of the Premiership stuff, but you know, that's incredible. I think the amount of stress that is going through their back and their recovery isn't enough. Obviously, there's an interesting concept where I think it's possible that kids at that age, they build muscle mass without the bone mass keeping up with it.
Yep.
So they're good at building muscle strength, but the bone strength doesn't follow. So there's a kind of mismatch.
It's a stressor. Yeah.
Yeah, I think.
And are they doing? I mean, a lot of the kids that we're seeing, actually, they're playing a lot of sport. They're putting a lot of load in themselves, but they're actually not. They're not great movers. They can't do a single leg squat. They don't have that nice posterior chain strength, or they might be quite unstable around their pelvis and their core. So actually, they're not doing a lot of the basics in terms of their programming to actually build that support to be able to cope with the demands of their sport that they're doing.
Yeah, exactly. I think actually, I mean, kids are doing it anyway now. And you know, when we were growing up, we never went to the gym, started lifting at age 14. They're all doing it now anyway. A lot of them. So I think actually we need to switch that around and be proactive and actually teach them technique, teach them. You know, I saw my son the other day doing a squat and he was on tiptoes. You know, like, you know, he's going up and down on, you know, he's like, I don't know what he was doing, but, you know, and it was the same with some of his.
With a lot of load or just basic squats?
Yeah.
Bodyweight squats,
So I think teaching them technique, doing the things that we do at an early age, and we're probably not doing enough is the answer. There's the other bit to.
Yeah, I think education is, you know, education of kids, education of, you know, how impactful having reasonable posture can be on reducing sort of the incidence of sort of back pain. But I think that's a massive area to actually improve society's burden, because if we can get people managing their health and their well-being better from an earlier age, then hopefully 10, 20, 30 years down the line, we're not going to see the same numbers.
Yeah, exactly. I mean, I saw a 18-year-old fast bowler who's apparently going to be good soon. And guess what? He was a fast bowler, tall, classic, past stress injury kind of candidate. Guess what? He didn't do it in the bowling. He did it in the gym.
Oh, wow. Okay.
Yeah. You know,
do you see that often, though?
Yeah, I do. Rugby and football. So he was doing why would a fast bowler do a jump squat? But he was doing a jump squat.
Yeah.
And actually, I don't know too much about jump squats, but I know your feet need to be on the ground at every point. Yeah. And I saw a video of him doing a jump squat, and his feet were leaving the ground with the weight in his hand.
Okay.
Which is insane, really, isn't it?
Yeah.
Actually, a lot of people do that. But jump squat, your feet has to be...
Yes, they need to be planted.
Yeah.
And generally we do sort of plyo and vertical jumps. I tend to not use load.
Yeah.
So we're doing body weight stuff, but, you know, looking at sort of power output. But you need very, very good technique if you're thinking about doing a jump squat or something with load like that.
Yeah, exactly.
So just moving forwards a little bit, what are some of the common spinal surgeries that you might be performing? You touched on that maybe 6-7% of your patients that come to you might end up with some sort of surgery. What are some of the common techniques that you're undertaking?
So we do I do injections firstly. So there's very common, very easy procedures to do. And we said, the main reason is to aid their rehab, reduce sensitivity, inflammation. Reduce their pain levels, give them a break from the pain, try and reset those things we were talking about, kinesiophobia, or if you're not making any progress. My experience is that when you're in pain, muscles don't activate no matter how hard you try.
Definitely.
People can sit there trying to do bridges or glute squats or whatever, and it doesn't do it. So injection's the most common thing. And then a microdiscectomy. So in layman's term, I guess it's shaving of the disc. So a disc prolapses out, and you've tried all other measures, physio, injections, everything. It hasn't worked. So you make a small incision in the back, go through the muscle, you shave a little bit of bone away, and you only take that portion of disc away, which is compressing the nerve. You leave the rest of the disc that's in between the bones.
And that's minimally invasive.
Yeah, it's minimally invasive. It's on average 40-minute procedure. You could even go home that same day. I tend to keep people in overnight because you can, and they get an extra they get an extra session with the physio. And also you don't know who's at home with, if they've got 4 kids at home, they
need a little bit of rest.
Exactly. Yeah. So, and that's, an incredibly successful operation. Normally, obviously there's a recovery period.
What is the recovery period for that?
Yeah. So microdiscectomy. So up the same day, if I do it at, let's say, lunchtime on a Thursday. So by late afternoon, they'll be up, pottering around, going to the toilet, home the next morning. Some generic advice that our in-house physios give for the first 2-3 weeks. I just tell them to just keep walking, don't do any heavy lifting, bending, twisting, things like that. So around day 17 to 20, why day 17 to 20? Because the wound's normally healed by then. Can start physio. And keep it simple and about mobilization and gentle muscle activation in that first 3 weeks. And you can get on an exercise bike at week 3. You can get in the swimming pool at week 4. And then, depending on your progress, reassess at week 5 or 6 and see if you're ready for loading. And it's slow, progressive loading because it's not so much about recovery from surgery. It's recovery from, let's say you had 7 months of leg pain.
It's the deconditioning.
It's your whole body's deconditioned. The people that have done really well from my surgery, some of them go on to injure themselves because basically what happens is they've had severe pain for ages. Surgery has, after surgery, it can sometimes take time for the leg pain to settle down. Sometimes often you get rid of, let's say, 80% of it.
A good chunk of it,
And then the rest of it takes time. Occasionally it just goes.
And, are you doing the microdiscectomies predominantly for leg symptoms?
Oh, yeah.
So, microdiscectomies are not known to change back pain.
No, they don't change back pain. You don't. You should never be doing a microdiscectomy for back pain. Yeah, no one should. But let's say you're someone that does, your pain's completely gone post-surgery, which sometimes it does. And you think, oh my God, 3 weeks later, you're thinking, well, I don't need to listen to his cautious advice. Those are the people that end up with calf tears, glute inflammation, IT band pain, because your body's not ready.
And so they really need to be coached through this and carefully sort of mapped out with this, with someone who's seen quite a few of these.
Yeah, exactly.
And particularly because there can be a degree of persistent pain, which is often where, say, the neural glides can come in and actually just building that stable base for someone once we can start gently getting a little bit of light load into them.
No, exactly. So a nerve will obviously be bruised from the compression. There's some pain that will go straight away. Superficial bruising of the nerve takes about 6 weeks to settle, what we call neuropraxia. Deep bruising of the nerve can take months and months and up to a year. We call that axonognesis. It has the ability.
And that's slow to.
It has the ability to recover. And then unfortunately, there's a small portion of patients, probably about 5 to 7%, where they have an element of permanent damage on the nerve. But that's why it's important to do the right rehab before to get it in a timely manner. So, 90-something% of people will do well from it.
Yeah. So you touched on some injections, and they're all steroid injections generally. You're not using sort of your PRPs or your stem cells yet. Do you think there might be a place for that in spinal
the PRP
treatment? There are a few people who are doing it.
Yeah, in the US especially. So I get people. I'm yet to find someone that has got better from the PRP, by the way.
Yeah.
So a lot of people go back to the US, spend a huge amount of money because it's I don't know whether it's Cleveland or my practice, but I see a lot of Americans.
Yep.
And it might be because, because they see the
Perhaps
Cleveland
name.
Cleveland name.
Yeah.
And also location.
Yep.
So they do it there. I'm yet to find someone that's got better from it. The evidence is weak for that, and you pay a lot of money for it. So I'd stick to things that are either harmless, don't cost you a lot, or are known to be effective.
Yes.
So when people say to me, should I do this spinal decompression? I've been told I need 10 sessions. Well, actually, I have seen quite a few patients that have got, at least temporary or short to medium term relief from it. I haven't had no one that I know of that has had a...
Well, what's the worst that can happen with it?
Yeah, exactly. Like
it's relatively harmless. Is it going to 100% guarantee a change in pain? Well, it's probably relaxate. The amount of tension to actually gap your spine is enormous.
Yeah, exactly.
The spine's a strong structure, but what are they acting on? Maybe they're acting on the deeper spinal system to just get a little bit of relaxation of those muscles.
Yeah, and often actually the difference between talking about sciatica, whether it's the arm pain or leg pain, the difference between pain and no pain is millimeters.
Yeah.
You look at the amount of people. My favorite thing when people have nerve pain down the arm is just open the shoulders out.
Yeah.
You do that, it's gone.
Yeah.
Why? Because you just opened the nerve channel out by
the canal a little bit more
by 3 millimeters.
Yeah.
And that's why I think taping's underused in the neck.
Yep.
It's
it's very good from a postural point of view to sort of hold, and it's quite easy when you're assessing the neck to actually assess the neck and reposition someone, and suddenly that feels better, and know that there's a mechanical and biomechanical change that you can make that's going to improve things.
Yeah, exactly. Going back to the operations, so I do probably neck surgery is the neck one, what we call anterior cervical surgery.
Yep.
Where you make an incision on the front of the neck. That's for people that have arm pain that is disabling and it hasn't gone with conservative physio injection measures. It's my favorite operation.
Okay. Why?
It's you cut the skin.
Yep.
And then you don't cut anything else.
Okay.
You just retract. You take the disc out. You put these beautifully made implants in, which are completely different to implants that were made 15 years ago. So this operation's been going since 1968. So
it's got some pretty impressive data.
And it's a one operation that is standard throughout the world.
Yep.
Everyone does it.
Yep. So that's the gold standard.
The approach is the gold standard. The thing that's really changed is the implants you put in. They are significantly improved from even 10 years ago. I only ever have issues now with the implants in people who are osteoporotic.
Okay.
So postmenopausal women, think about it. Older people in general, think about it.
Yep.
You need to look at bone health.
Do you screen for bone health beforehand?
Yeah, if you're putting in metalwork, you screen for bone health. It's the only time I have problems with metalwork because obviously it's like, it's like if you're putting a screw in a wall, if it's wet wood, it's not going to take the screw. It's just going to spin on it.
Yep.
There's nothing as surgeons we can do about that except prep beforehand. There's nothing you can do during surgery or afterwards if the bone doesn't hold it.
Yeah.
It's a great operation because it's not your tummy, it's not your legs, it's not your back.
Yep.
You can get up and walk around.
Yeah.
And funny enough, you don't have so much pain in the front of the neck. It's more the back of the neck, and that's partly because during surgery we take the shoulders a bit, but actually more so that you're actually restoring the lordosis and the fascia at the back of the neck, and the top of the back gets a stretch.
Yep.
And it's not allowed to relax because you put an implant in there. So it just takes a bit of stress relaxation.
Yeah.
And but you're walking around straight away because it's your neck, and
Okay.
you feel pretty normal, and people can go to work in the week. And
we haven't touched on neck pain much today, but the same sort of applies in that, okay, we want to try to gently move. We want to gently add some load and control into that area. But a lot of this is driven from the forward head postures, isn't it?
Yeah, exactly.
And you get, a little bit more narrowing and stenosis around the neck sometimes.
Yeah, I think when people talk about, that desk posture, what that does is it puts more stress on your joints, on your disc, and narrows down the channel.
Yeah.
So it's not about, people. There's that old myth that everyone needs to be upright. You've got to be careful of that because you might be hyperextending.
Yeah.
You might be
through your thoracic spine or through your lumbar spine.
Yeah, through your low back. Actually, no, it's more about neck position, isn't
Yeah.
it? And positioning your shoulders and the position of your upper back from, what we call the ziphisternum, the underside of the bone there, upwards. It's that position you're looking at and the position of your neck relative to that.
Yes. Yeah.
Because if your upper back is not right, it's flexed, then you will compensate in your
through your neck, exactly.
neck.
And there's always, if your neck's inherently, if your neck's a little bit mobile through your mid portion, you inherently sort of stiff through your thoracic spine, trying to get some stability somewhere.
Yeah.
So actually, it's about sort of trying to optimize that whole spine.
Yeah.
Rather than just the neck.
So everything in life we do is the closed system, isn't it? You're closing.
Yes.
Like that.
Yeah, we're in front. Everything's in front of us.
Like that. And even when we go to the gym, do exercise, most people are doing these exercises. Actually, we should be doing.
Yeah. To open ourselves out. Some pulls and really trying to, which is where, again, touching back on Pilates, even yoga at times, is very good for opening ourselves out, for mobilizing the thoracic spine. And for me, having a really mobile thoracic spine is really key to helping offload your lumbar spine, but also offloading your neck as well. Would you agree with that?
Yeah, 100%. It's a forgotten bit because not a lot of people get thoracic pain as such.
Yeah.
You can get
myofascial pain maybe in the thoracic spine.
Yeah, myofascial, but it's the least common of the three, by far. And so it gets forgotten a bit. So thoracic rotation, is key. Extension, what is your musculature like in extension? If you're a forward flex person, like I said, your neck's going to be like that. If your thoracic rotation's not good, you're going to be rotating in your lumbar spine, which is not designed to rotate.
No.
So a golfer that has no thoracic rotation will be rotating through their lumbar spine.
Yeah.
So I often get asked that, should golf irritate my low back? Well, if your technique's correct and you've got adequate rotation, then it should not. But if your technique's not right.
And it's hard to nail the right technique with golf, but.
Yeah, exactly. So,
but you need that mobility.
Yeah. But
and that strength.
Yeah, exactly. But some professional golfers don't have the classic golfer's technique that you're taught in a textbook.
Yeah.
And that's how they injure their low. They're just hugely skilled, hugely talented, and have got away with their technique.
Yeah.
But unfortunately, it impacts their lumbar spine.
Yeah, completely. Touching on one, are there any innovations in spinal surgery that you're sort of super excited about over the coming sort of 5, not even sure what 10 years might look like?
If you'd asked me a couple of years ago, I would have said robotics, navigation, and being able to, have the goggles, where you can see the patient's anatomy and everything like that. There's all sorts of innovations gone, and I've been pretty good, to be honest, about being skeptical about the right ones and being excited about the right ones. So robotics is still potentially there. Being able to use a goggle where you see a patient's anatomy when you've not even started operating on them, or
does that help to improve the accuracy?
Yeah, if you can see it beforehand, if you can teach it to trainees, if you can plan, a lot of surgeries in planning.
Yep.
I remember reading Alex Ferguson's book. He's like, the day of the match day is a match day where everyone's having fun and relaxing. When I turn up for surgery on that day, for me, it's a fun day.
Yeah.
I don't want to be sitting there stressing, like looking at the spine and, my God, what am I doing today? No, for that.
So it's the prep beforehand.
It's the prep beforehand.
Yep.
But I think you can't look past AI now. So, and it's not even going to be 5 or 10 years. It's going to be.
Oh, it's happening now.
It's happening at a rate where if you go on holiday for a month, you miss something.
Yeah. It's remarkable how we're integrating into our practice even, and what. Yeah. So
what it can mean. I mean, in healthcare, as usual, healthcare is the slowest to uptake technology in of this kind. I mean, just in spine surgery alone, there are, from back to front, in your processes, in triage of patients coming to you.
Yep.
In the NHS, that's more important because you've got millions, as you said, the figure there. Imagine all those trying to see us in the NHS.
Yeah.
Well, actually, if you have an app, which one of my colleagues is designing, which where you fill out a questionnaire and you upload the scan, and it gives you a percentage of where you should go.
Oh, really?
Yeah, so a triage process, and if it says more than 50% or whatever it needs to see a surgeon, then you go and see the surgeon. So
Amazing.
triage and then process.
Yeah.
You know, like, you know, in your admin processes, dictations, all the, like, all
Yeah,
the.
I mean, we use it for our clinical notes now, and it's just such a time saver.
Yeah,
So you can
exactly.
focus on the patient now.
Yeah, exactly. And, and it comes out, these are all first generation, right?
Yeah.
So 3 years from now, where are we going to be? 5
Yeah.
years from now, it's just going to be the thing. And then there's, all sorts of clinical things.
Yep.
Let's go back to the NHS a second. So there's a thing, as you know, called equina syndrome, where the nerves of the bowel and bladder get squashed.
Yep.
The problem is, if you come to the Royal London Hospital, which is the major teaching hospital, you're fine. You'll get a scan that evening. If they think you've got it, if you've got it, you'll end up having surgery. If you go up to any of the other hospitals, peripheral hospitals, there is no scan out of hours. There isn't anyone to report it, and you've got to get yourself over to a major hospital.
Yep.
So
it's postcode dependent almost.
Yeah. But you don't know. I often say to friends, colleagues, family, whatever, if you have that problem, go to a big hospital. Don't go to one that doesn't have a spine service. So AI would be able to look at the scan and tell you whether you've got Cortical syndrome based on your symptoms.
Yeah.
So you don't need a radiologist. You need someone that man the MRI scanner, which is a bit easier.
Because radiology, they're diving into sort of some of that AI reporting these days, and that's only going to improve with time, I'm sure.
Yeah, exactly. And there's just so many other clinical aspects where, AI is just going to make a difference, and having accessibility to, I think even research, we used to sit there collecting data on a computer and all this kind of stuff. Now you just get, what's that LLM thing, the language model, where it just reads the notes.
And it just collates the information for you.
Collates the information for you. And, the days when you read papers, I mean, I think within 2 years, one will not be holding a paper in our hand and reading it. It's just going to go up on.
I still like the book. I still like having that physical. Yeah. But I get what you mean. I know we're a little bit time pressured, so I just want a couple of other quick little questions now. So whether you're an elite athlete or Joe Blogs or the weekend warrior who's having a bit of back pain, I think our daily habits really have a massive impact on what contributes to back pain. Yes, we see trauma, but so often it's what's happened in the preceding 1 year, 2 year, 5 years that have led to that sort of situation of back pain. So what are the top sort of the 3 big things that people should focus on to try to reduce back pain?
So sleep.
Yep.
I'd definitely put it number 1.
Yep. Sleep over exercise?
That's going to be my number 2.
Okay.
Because I think if you don't sleep and exercise, that's still not good.
Yep.
You could injure yourself. So I think I'll put sleep first.
Yeah.
Then exercise. And then probably education, which includes diet.
Yeah.
Yeah.
Okay.
So those 3 things.
So diet, a quick one. Does being overweight increase your incidence of back pain? Because there's studies out there, and we can put them in the show notes, that suggest it does.
Yeah, I think so. Yeah, I mean, you're more likely, it's a seesaw in your back. There's a load going through your back every day. There's your back's ability to deal with it. If the load going through your back is more than the ability to deal with it, you're going to get
So will the GLP-1 agonists, for someone who's quite overweight or obese, and back pain is a big issue for them, could these have a role to play in managing that cohort?
Yeah, 100%. Obviously, it's just kicking off now. The GLP agonist is like AI at the moment, isn't it? It's just I think I found out the other day there's 150 other other ones that are in the process of being trialed
in the pipeline.
In pipeline, and I think for the big pharma industries, this is like their big thing because it's as dead cert as pharma gets.
Yep.
But yes, of course, like if we're reducing obesity, then we're probably going to reduce the incidence of back pain. The other nuanced thing about that, I would say, is that you get people who obviously different levels of motivation to reduce their weight loss. There's the ones that can't do it, the people that try and fail, people that try and do it slowly or a bit up and down, and the people that really go for it.
Yeah.
I see. So actually, funny enough, in the latter, they often get back pain.
Yes. Because they push load very quickly.
They're loading way too much and their body's just not ready for it and not used to it. And actually, they're still heavy, by the way. And then they say, oh my God, I've lost 24 kilos and all I have is back pain now.
Yeah.
Does one get back pain when you reduce weight? Actually, no, it's just the process of you getting there. So I think those GLP agonists will help the diet aspect, the hunger and diet aspect of it more, and not, sure, you should
not
exercise.
necessarily reduce back pain because they're suddenly reducing the force. You're suggesting.
Exactly. Yeah. So instead of burning 4,000 calories a day from all your activities, you just burn 2,500, but you've reduced your calorie intake to 1,300 or 1,500, which is perfectly reasonable.
Yeah.
I think, like everything, it's about habits. Everything is about habits. People get back pain because they get out of habits.
Yes.
Habits of sleep, habits of exercise, habits of diet, and stress is a big thing. So it is a psychological thing, but it's a chemical thing. Stress raises your cortisol levels.
Yeah.
Raises your inflammation. So
and if you're in a prolonged state of sort of high cortisol, adrenaline, then that can lead to a whole host of changes down that pathway as well.
We all know ourselves, if we have like late nights every day for a week at work, and you're working hard and you're sleeping half an hour less every week, something's going to hurt at the end of the week.
Yeah, it adds up.
Yeah,
definitely. Yeah. So that recovery you put as number one.
Yeah.
Yep. Okay. So posture. Just quickly touching on posture. How much do you think having good posture negates getting back pain, or does bad posture contribute to low back pain or neck pain?
Yeah, I think it contributes to it. There's no doubt. Like if you look at studies that have been, for instance, on disc pressure, so pressure in your disc, the disc is the bit between the bones, in different levels of posture, your disc pressure increases dramatically.
So flexion or slouch postures increase the disc by pressure by about 50% of standing, I think.
So if you're lying down, that's the lowest. Standing up's not too bad. Sitting's not too bad. And then sitting forward a bit, it increases. Sitting forward a bit with a weight, is even more.
And then flexion also increases.
Yeah, exactly. So I think it does. What we need to respect is the fact that everyone has a different posture and a different optimal.
Because there's no one posture that is perfect, because people come in and go, should I be sitting? No, well, actually you're causing overload on your thoracolumbar junction by sitting in that hyperlordose position.
I'm trying to sit upright where you might be not doing yourself a favor by that. But it's just trying to bring everything to you. And remember, actually, we need to be open in our shoulders. We need to be tucked in our neck. We need to be up against our chair and supported, or if you've got another technique, the most effective way is actually to keep moving during the course of the day.
Yeah.
What's that figure? 74% of people have a reduction in their back pain when they change their position every 40 minutes or something. So that's the most effective thing.
Are you an advocate of sit-to-stand desks?
Yeah. I think there's no doubt that's, it's like being in a car. If you're in a car journey and you stop to get out and walk if you had a 6-hour car journey and you got out to walk every 40 minutes for 10 minutes, which we all don't do, of course, because that's usually time consuming. Then
painful
you'd be totally fine at the end of it. You sat in a car for 6 hours, you're going to come out stiff and sore.
Exactly. So it's this ability to change patterns, to change position, to change that load.
Yeah. So when people say, should I sit or stand? It's not that. It's about changing position.
Yep.
Now, occasionally there is a particular position that's really sore. Like sitting. I can't stand. So okay, fine. Then you stand more, but walk around more when you're on a call. Walk. Go to the water fountain, go, move around. It's incredible how during lockdown and COVID, everyone's step count went down massively.
Because everyone was sitting.
They didn't realize actually walking.
The commutes.
The commute, just getting water, going out for lunch, coming back. Oh, you got 8,000 steps just from doing that.
Yeah. And that incidental exercise is actually incredibly important for us.
Yeah. So this is actually, it's funny you should mention that. I think that's one of the most underrated things. It's not about going to the gym for an hour. It's all the things you do around that, that built into your daily. So if you go to work, sit all day long, and you go to the gym for an hour and 20 minutes every day, or, whatever, that's not the same as like walking 40 minutes to work or cycling 40 minutes to work, walking 40 minutes back, and then when you're home being up and down and everywhere. My job, I don't sit for longer than 5 minutes at a time. So
apart from when you sit here and chat to me.
Exactly. Apart from rare things like this. So I'm always moving, and then you pick it up on the Apple Watch, and people say, how do you average?
Motion is lotion.
Yeah, exactly. How do you average that many steps
Yeah.
in a week. Well, actually, it's not my gym. It's well, obviously that contributes. It's what
It's
I'm
just being active through the day.
yeah, passive exercise.
Yeah.
Yeah.
Okay, so I've loved today, Monty. It's been awesome to just chat through a lot of this. I've learned a lot, so I hope a lot. You've covered and been incredibly articulate about a lot of, because it's a complex area about sort of back pain in general. But if to sort of wrap it up, would you have one piece of advice that you could give to people with chronic or persistent back pain?
Well, the thing I tell them when I'm asked that, again, I'll revert back to the touchline on the weekend, is find a good physio.
Yep.
And if you don't know one, fortunately, I can recommend one to you.
Yeah.
Or it depends on where they are. And it's got to be convenient. It's got to be, there's no point in giving them an hour's journey each way and everything. Because you don't want to see a surgeon first up.
Yep.
So I don't recommend going to myself. The physios, like yourself, especially the experienced ones, and there are different levels of physio, will then know who next to farm
The triage, if necessary.
Yeah. So do you need to go and see the Pilates instructors? Do you need a bit of osteopathy? You need S&C, or actually, you need to go and see this guy, get a scan. I don't want to treat you until you've had a scan.
Yeah.
Sometimes you guys say that about 10% or whatever at the time. My biggest advice, find a good physio.
Yeah.
Stick to them, or find a good physio company, because that physio isn't always going to be there.
Yeah. Very true.
Exactly.
They're often busy.
So, yeah, exactly. So when I refer to you guys, I'm referring to your company.
Yeah.
Might refer it to you, but it's to the company, because people are away, people go on maternity leave, people go on holiday.
Yeah.
So.
Yeah. Okay. That's great, because I think it's, a lot of people out there are stuck with where to go, what to do, and, persistent back pain. And maybe that's another topic to get you back on and talk, because it'd be interesting to sort of dive in a little bit deeper with some of that. But Monty, it's been awesome to have you on today. So thank you. I hope you've enjoyed it. And
great.
we'll chat soon.
Awesome.